My name is Dean Bartholomew. I'm a family physician here in Saratoga, Wyoming. The use of the POLST form is voluntary. What the legislation has done, though, is that it allows for this form to be completely portable, so that a form that is filled out, let's say by myself here at my clinic, can be taken to a surrounding community hospital and can be followed as a medical order. At this point, I'd like to go through the form and really delineate what we do line by line. The top of the form is simply name, date of birth, social security number, all of the nitty-gritty of patient information. The form starts with box A, which is CPR. So the form states if a person is found to have no pulse and is not breathing, does the patient want to have CPR or not have CPR? This then starts the treatment tree going down from there. Obviously, if the patient wishes to be DNR and does not want to be resuscitated and allow this natural death to happen, then the POLST has served its purpose from that standpoint. If the patient wants CPR, that's well documented, and that would be the case. Going down to box B, now we're getting more into the actual interventions that a patient may want if the patient has reached a point where they're very ill, maybe there's been some type of change in their status. The example I like to use with my patients is that, again, we're using this in an anticipated last year of life. And so I tell the patient, if what were to happen if you were to have a stroke, let's say, and suddenly there was a significant change in your status, would you want us to, number one, pursue full treatment? That could include intubation, putting in an airway, transporting to the hospital, using machines to help with breathing, placement in the ICU. So really aggressive treatment. So that is one part of the treatment option there. The second part is selective treatment. So what I tell patients, maybe in the nursing home as well, maybe we would like to try IV antibiotics for a severe pneumonia, or maybe you would want to try some IV fluids if you're dehydrated. So selective treatment that is not maybe overly aggressive for their situation, but still allows for us to maybe monitor as they go through a medical situation. And then the last part of section B is comfort-focused therapy. So this would be, again, the example of, okay, you're in the nursing home and now maybe there's been a stroke and things don't look well, and maybe it would require some pretty aggressive treatment to keep you alive. What would you want us to do? Would you want us to keep you comfortable and allow this natural process to happen? Part C, or box C, starts to talk about artificial nutrition and hydration. Again, this goes back to if a patient wants to be aggressive, then there's a box there that says they may want to have long-term artificial nutrition or fluids. Maybe they want a trial period. Again, maybe they have severe pneumonia. They want some hydration to combat dehydration, to give them a time to see if the body's going to recover. Or there's a box there that says no artificial nutrition. I've reached the end of life and I'm okay with that. Box D is an open box that we've titled Medical Conditions and Patient Goals, and that's a place there where the patient can say in their language, here's what I want. And that may be some place where they address dialysis. If it's a patient who is on dialysis or has end-stage renal disease, they can make their wishes known of what they want to do with their dialysis. And then the form ends on the first page with box E, and these are where we put in the signatures. And again, it's very important to note that the form is signed not only by the provider, but by the patient or the patient representative, showing that there was a conversation had, that the family, the patient, all are aware of the decisions that were made and that they're on board with that. One addition to the form that was made during the legislative process was there's a checkbox now that says that the patient can check and say, if I get to a point where I'm not able to make my own decisions, I do not want this reversed. And there was concern during the legislative process that that a patient may want to make their wishes known, and then let's say they want comfort care, but then maybe if they got to the point where they couldn't make their own decisions, that a family member or the power of attorney could come back and change that, and which may be against the patient's wishes as they had made them known previously. And so that checkbox allows for the patient to say firmly, these are my wishes, don't change them.